Hello everyone, welcome to Assicon 2024 Spine Surgical Suites.
This video is about minimal invasive transforaminal lumbar interbody fusion, precision and safety redefined in new gold standards. We all know that a conventional transforaminal lumbar interbody fusion done for lumbar fusion requires positioning of the patient prone, standard exposure, midline incisions, exposure of superficial and deep muscles, followed by facet resection, disc preparation, putting in graft, antibody cage device, decompressing both the site, both the nerve roots, instrumenting it. We all know that TLIF is the gold standard of lumbar fusion because of multiple advantages. That's the extracanal procedure, leads to less battering compared to posterior lumbar interbody fusion, resulting into less fibrosis, and has a wider applicability in higher lumbar discs or even in upper thoracolumbar junction as well. Now, the same transforaminal lumbar interbody fusion has certain disadvantages in a conventional technique where muscle dissection leads to more morbidity, more pain, blood loss, infection rates. And minimal invasive takes away the disadvantages of a conventional TLIF. And it has now lately become the gold standard of doing a lumbar interbody fusion. MIS TLIF is a microendoscopic tubular fusion using operating microscope through tubular portals, which are fixed cylindrical tubular retractors, where muscle retraction is not required, and you can do a fusion and bilateral decompression only by unilateral access without any requirement for muscle retraction, actually only by paramedian incision splitting the muscles without any need of splitting or stripping the muscles off from the bone. And the indications of MIS TLIF are as wide as any conventional TLIF and even bigger and better, that it can now be utilized into not only in the lumbar spine, but also in thoracic spine and the wings in cervical spine, expanding not only degenerative pathologies, but also other pathologies. We also must remember that MIS TLIF has taken away all the problems and morbidities of open TLIF, which used to come with access-related morbidity resulting into muscle damage. And this happens because the basic principle of sparing the posterior ligamentous structures and also having a paramedian muscle splitting approach which spares the multifidus, resulting into advantages of minimal access surgery in spine surgery. The advantages are obvious, which cannot be neglected. The incisions are very, very small, resulting into less blood loss, less post-operative pain. As the muscles are not damaged, the pain is less. Patients can be mobilized the same day, resulting into this procedure now lately being classified as daycare procedure, and now can be done as awake fusion as well. We have been performing it for the last 5 years already. Bilateral decompression can be done by same incisions without having to need to do a exposure on the other side. And in obese patients, you can imagine where the incision is so big, the same surgery can be done in thin patients or obese patients. The incision side remains the same. And remember, because there is no dead space, the muscle stripping or damage is nil. It's a very forgiving, particularly in patients where dural leak happens. Now, MIS TLIF has its own steps. We will be going through these steps one by one in detail, but it goes through the most important aspect of microendoscopic surgery is patient selection and planning. And 80% of surgery comes before you actually wash up for the surgery. It requires patient selection, meticulous patient selection, following the surgical ladder that you take up the most simplest cases in the early years of your life, and planning your cases very, very well, and take into consideration the patient's anatomy. Every patient has a different anatomy, be it the orientation of facet joints from where your tube is going, be it the orientation of spinous process, be it the orientation of the pathology, presence or absence of a migrated disc fragment or a facet cyst, etc. So all these things have to be taken into consideration before you plan your surgery. And then once the tube gets dogged, you're taken into consideration all the anatomical parameters and the variations. Then the internal part of the surgery, which is the target surgery of decompression, both the nerve roots, and fusion, preparation of the end plates and fusion, putting in graft and cage, remains the same. Just that it happens through smaller incisions and through the tubular portals, reducing the overall morbidity of the fusion surgery. As we discussed, pre-operative planning takes the precedence in any of the MIS procedures. We will be discussing some of it in detail. The pre-operative planning involves having the correct patient, having chosen the right patient right from the beginning, and knowing the anatomy in greatest possible detail. Remember, the vision is tubular, and that is why the exposure is also tubular, and that's why your understanding about the anatomy has to be meticulous, and there has to be a 3D visualization of the anatomy of each patient, because the visualization is going to be restricted only through the tube, and that's why a targeted surgery is done only when you are very, very well aware about the anatomy, and this is something very, very important. Apart from understanding of the indication and anatomy for MIS TLIF, you also must be aware about the tube docking principles, which is paramount to avoid any hassles during the surgery. We must know what exactly is the cause of symptoms, because it's a targeted surgery, a presence of cyst, a disc, a migrated fragment, or a bilateral ligamentum flavum hypertrophy with facet hypertrophy can be contributing to symptoms, and everything of this or all of this can be taken care only by tubular vision also, if you have planned it well, and you can achieve all these aspects of decompression by a tubular approach by using tubular retractors. We must be aware where the fragment is lying, whether it is up migrated, down migrated, whether the facet cyst is on one side or the other side, what part of the facet, whether it's medial facet or the far lateral aspect of the disc, which is compressive in causing the symptoms. And this is something that you must be aware about. It is as similar as in any conventional surgery, but in MIS surgery, you must be even more aware about this. Not only this, but also the anatomy of the patient, both the clinical anatomy and the radiological anatomy must be very clear in your mind, with the understanding about the spinous process, the spinal lamina line, the lamina and the interlaminar space, because this is what is going to be seen to you by a tubular way and in the tubular retractors that are going to be placed on the spinal lamina junction. We will be seeing this in the surgical video that will come up now. Pre-operatively, you must have all these instruments on your table. Remember, long instruments and bayoneted instruments are something that come very important and very handy while doing MIS surgeries, so that your hand doesn't come in the vision of your vision, and then you can actually have these instruments very handy. Pre-operatively should be kept on the table. Positioning of the patient is same. However, in patients with very, very obese or a big torso, using a Jackson table like we have been using lately is something that comes very handy, resulting into less bleeding. Remember, bleeding is the only enemy of MIS surgery, and it's very important to have a free abdomen to prevent bleeding during the intraoperatively, because reducing the bleeding will make your surgery far more easier. And all these things have to be taken into consideration even more meticulously than what you do in your open conventional surgery. The tube docking, again, this is something we must remember. It's different from open surgery where the incision is paramedian, not midline incision. You do not go by midline incision, it's paramedian, 4 to 6 centimeters away from the midline. And this is placed on the line of the pedicles, between the interpedicular distance of the two vertebral bodies. And then you cut through the skin incision, cut through the fascia, feel through your fingers, and with the help of your sequential dilators, without cutting or stripping the muscle, your dilators help you to place the right placement of the tubular retractor, which can again be angled in one or other direction to do bilateral decompression. The angle of the tube must be in line with the disc. This is very important to have your preparation of the end plates done very well, so that you don't subside into the bone and don't do any damage to the end plate. And this is something that you must remember, that your tube should be placed in line with the disc. The facets are then removed like in any other open conventional transfemoral lumbar interbody fusion, following which, after the facets are done, you do a discectomy and then take care of the exiting and traversing nerve root. That's the triangle where you actually work through into the disc space and create a box cut into the disc annulus, resulting into disc preparation. And very well, you can prepare the end plates on the opposite side as well, only by these tubular dilators as well. Following which, after you have done your end plate preparation, your graft and your cage, you can do over-the-top decompression by just bending your tube or angulating the tube and tilting the patient to the other side. And a very well decompression of the opposite side can easily be done in a most optimal and most efficient manner without any doubts. So people who have doubts that MIS surgery results into suboptimal decompression, please take out that from your mind, because very well decompression can be done on the opposite side only by the same side bending technique. It comes very handy by tilting the tube towards the opposite side. This is a video of a patient with L4-5 lytic listhesis, and we have done MIS TLIF in such patient from the right side. So that's the right side. As you can see, the orientation of the patient, and the top edge of the screen is the medial spinous process. The left side is the foot side, the head side, and the base of the screen is the right side of the patient, from where the tube will come in. Paramedian incision, 2.5 centimeters, with the help of a guide wire under C-arm guidance and using sequential dilators. You don't strip or the muscles away from the bone. These dilators actually split the muscles, allowing the muscles to split up, making space for the tube to go in and sit there. And this docking of the tube is done on spino-laminar junction, where exactly at the base of the spinous process, the lamina starts, or the base of the lamina and base of the spinous process confluence. That's where your tube gets docked there. And then this tube is fixed to the fixed table mount, making it a fixed dilator in the patient's body there. And without any need for larger incisions, your access to the area of interest is complete done, and now you can actually proceed with your surgery. Using a microscope, again for your orientation, that's the head side, the medial side, the right side, the base of screen, and the foot side. Using a long cautery tip You cauterize, and that's the joint line, as you can see. Take away the muscle that creeps in from the base of the tube. And that's the inferior facet of L4, and that's the superior facet of L5. You gradually start taking down piecemeal. The inferior facet is completely removed. And you continue doing bony resection of the lamina till you actually start a complete release of ligamentum flavum is done. The overhang of superior facet, which runs into the foraminal area, is then partially taken down, again releasing the ligamentum flavum completely. Tease out the ligamentum flavum, and you land lateral to the equator of the dural sac. As you can see, the L5 traversing nerve root from superior to inferiorly going downward. You can add foraminotomy to this, achieve hemostasis, and the first thing that you come to see across is the shiny surface of the annulus or the disc. This is here where you use your patty cottonoids in the axilla of L4, in the foramen of L4, and in the shoulder of L5 to give you a complete exposure of the disc, where you can actually start doing a box cut using a knife and preparing the end plate aggressively using puckas and dilators. And you can actually do an end plate preparation very well on the opposite side as well. Following which, use of funnel to get your graft in. This graft is nothing but the harvest from the inferior facet that we have resected there. Once your graft is filled in, appropriate size cage is then inserted and checked on C-arm. Now this technique, this is called wanding, where you tilt the tube towards the opposite side and tilt the patient away from you to give you a direct view to the opposite side. As you can see, tilting the tube to the opposite side and tilting the patient away from you, giving a view under the base of spinous process. And that's when you again start resecting the base of spinous process, removing the whole of ligamentum flavum on the opposite side. As you will see, gradually we will move towards the inferior facet on the opposite side, which is the left side, and you will be able to see the whole nerve root L5 on the left side as well, without having any need to expose on the opposite side through the same incision. And this is what is called over-the-top decompression. As you continue seeing removal of the ligamentum flavum, you can actually see the shoulder of the left-sided nerve root. With the help of your nerve hook, you can actually feel the whole of shoulder, the axilla, and the foraminal area. Both the nerve roots are very well clearly seen. And your decompression is complete. You can actually visualize the whole nerve root from shoulder right the way, all the way into the foraminal area. This completes your interbody fusion and decompression work. And this is the time when you call it a day and bring out the tube. So this is the beauty of the tube. As the tube comes out, you see the muscle just falls back in place and the fascia also falls back in place, leaving behind no dead space for either hematoma, or even if one has a dural leak, there will be no place for a dural leak to get collected, resulting in pseudomeningosis. So it's a very forgiving surgery, and the incision side is 2.5 centimeters and a fusion is done. And this is when through the same incision, you put in your percutaneous pedicle screws to get, and this cage placement is seen very well there. And this is the time when you do a percutaneous instrumentation using a C-arm guided pedicle screw fixation in these patients to complete the instrumentation of the TLIF part. Again, this is again done under C-arm guidance. And now this is the left side of the surgeon, of the patient. As you see, the cage is in place. The incision is given lateral to the lateral wall of pedicle using cannulated needle. And the whole procedure is done under C-arm guidance. The needle is placed at 9 o'clock, and from 9 o'clock, you move into 3 o'clock position, touching the medial wall of the pedicle. And remember, this is the point where medial wall of the pedicle gets touched. You must have crossed, you should have crossed in lateral view, you should have crossed the posterior vertebral body line. And that's very important. This is the single most important point, where the tip of the needle, when it touches the medial wall of pedicle, the tip of the needle in lateral view should have crossed the posterior vertebral line. That's very, very important. And this is the point, like when your needle has crossed the posterior vertebral body line, you know that you're already in the body. And even if you're touching the medial border of the pedicle, you are through it, and you can further advance your guide wire. And then just, it's the simple thing of tapping, and your screws can then walk in. The guide wire, the blunt end. On the guide wires, you put in your dilators, the starter owl, and tapping. In order to reduce radiation, you can actually count the number of turns of the first screw. And as you see, only tap till the pedicle and get your screw in. And this is repeated on all the four sides, leaving behind all the four towers there, through which then your percutaneous rod gets engaged in these two screws, connecting the two screws there. The rod length is then measured, and the rod inserted, and INI is connected. The same steps are then repeated on all four screws. You can do a compression and distraction using special devices of percutaneous instrumentation, and see the size of incision of a MIS TLIF. As you see, the screws on the opposite side through the same incision from where the cage went in and decompression happened can then be done. And that's the size of the incision, 2 centimeter on one side and 1.2 centimeter on the either side. And the patient can actually be made to walk the same day, can be made to go home the next day. The pain is minimal, blood loss is hardly 50 ml, and this is something that reduces the morbidity significantly in such patients. So this is the beauty of MIS TLIF, that all these patients can then be, these are the end results. As you see, beautiful placement of the screws, because it's all C-arm guided, can be done for various indications in thoracic, thoracolumbar junction, high lumbar disc, low lumbar disc, lytic listhesis, or degen listhesis. And this is what makes MIS TLIF a gold standard for lumbar interbody fusion. Thank you so much for your patient hearing.